Hello everyone, welcome to another session of next Saviours Essential Question Series NEET PG 2025. Today we are going to have a discussion on the imaging for pulmonary embolism. That is, what is the role of D-dimer, the CTPA, the ventilation perfusion ratio, and the direct pulmonary angiography. NEET PG questions, at least one of these are going to be asked out of this topic. So let's evaluate the question. That means how to identify the question that it is related to the pulmonary embolism. You see, a 45-year-old obese female on oral contraceptive pills. Now, this is the first hint which is provided to you. Next, presents to the emergency department with a sudden onset pleuritic chest pain and dyspnea. These are the clinical features. Now, she recently underwent knee surgery and has been immobilized for the period of 2 weeks. So, if you look at these things which are provided, these three particular characteristics, the presence of the oral contraceptive pills in the question, that means the estrogens in the OCP, that increases the risk of hypercoagulability. Then, underwent knee surgery is indicative of endothelial injury and has been immobilized for the period of 2 weeks is suggestive of venous stasis. So, when you combine all three of them, what are these? These are the features of Virchow's triad. And Virchow's triad, it raises the suspicion of pulmonary embolism. So possibly the question we are dealing with is the question related to the pulmonary embolism. Now, if we continue with the question, there is a characteristic feature of pleuritic chest pain and dyspnea mentioned in the question, which is a classic symptom of acute pulmonary embolism with tachypnea, tachycardia, mild hypoxia. Even the ECG shows sinus tachycardia, which is the most common ECG finding in pulmonary embolism, and the chest X-ray reveals wedge-shaped opacity, which is also known by the name of Hampton's hump, which we are going to talk subsequently. So the first thing that we have identified in the question, that the question is based on pulmonary embolism, and as all of you know, that the clinical suspicion and risk stratification is based on Wells score, and these are the criteria, these are the points which are provided. The first one is the clinical sign of the DVT, which is leg swelling and pain. 3 points are given. P is the most likely diagnosis based on the clinical experiences. 3 points are provided. 1.5 is the point provided for tachycardia, immobilization, and previous pulmonary embolism history or DVT history, and 1 point each is provided if there is a history of hemoptysis or malignancy provided to you in the question. Based on that, interpretation is done. Like if the score is more than or equal to 4, then in that case the pulmonary embolism is likely, and you have to proceed with the imaging in order to diagnose this condition. And what the imaging is all about, this is why we are dealing with this question. So we'll be talking about that imaging in particular. But what if the score is less than 4? In that case, the possibility that the pulmonary embolism is there is unlikely. It could be anything other than pulmonary embolism. In that case, you have to proceed with the D-dimer test in order to rule out. So the importance of D-dimer is to rule out pulmonary embolism. And here in our patient, because he underwent recent surgery and immobilization, so the point 1.5 is given. He is presenting with tachycardia, point 1.5 is given. Pulmonary embolism is the most likely diagnosis based on the Virchow's triad, so 3 points are given. So in total, the score is 6. So here, the pulmonary embolism is most likely. This is the likely diagnosis on the basis of which we have to further continue with the investigations. Once you are aware of that the pulmonary embolism is the most likely diagnosis, then you have to start with the investigations. What is D-dimer test is for? You all know that D-dimer is a fibrin degradation product which is elevated in case of clot formation and breakdown. So it has a high sensitivity but very low specificity. Why? Because it is elevated in many other conditions like infections, in case of pregnancy, in case of malignancy. So this can be increased, as a result of which it has a very low specificity. And what is the role of D-dimer in pulmonary embolism? It is only useful to rule out the pulmonary embolism. So D-dimer is basically used in order to rule out this pulmonary embolism. Okay, and because in the question which has been provided, there is a high clinical probability, so D-dimer is absolutely not needed. We directly have to proceed with the diagnostic imagings. Now, as far as for your theoretical remembrance is concerned, this ECG findings in the pulmonary embolism, the most common one, as we have already seen, is the sinus tachycardia, and the specific finding which is related with the pulmonary embolism is the S1Q3T3 pattern, which is deep S waves in lead 1, Q wave and inverted T wave in lead 3. It is a specific finding, which is classic finding, but it is rare. All right. So this is a theoretical question related to the ECG findings. Yes. Importance are the X-ray findings or the X-ray identification. You see, majority of the time there is a possibility that X-ray might also appear absolutely normal. But if at all there are signs, then these are the signs which can be seen. One is a wedge-shaped opacity or the pleural based opacity, which is suggestive of pulmonary infarction. And this is known by the name of Hampton's hump. On the other hand, there is also a possibility of focal oligemia, which is decreased lung markings due to vascular obstruction distal to the emboli. And this finding is known by the name of Westermarck sign. So out of the two, majority of the times in your question, you get this Hampton sum because it can be easily identified in the lower lobe wedge-shaped opacity with the clinical question where the features of pulmonary embolisms are given, and then they proceed in asking about the diagnostic modality. Once we are done with the basic investigations, now is the time to confirm the diagnosis based on confirmatory imaging. And the first imaging modality is the CT pulmonary angiography. You know, this CT pulmonary angiography is the gold standard non-invasive imaging for diagnosing the pulmonary embolism. It provides direct visualization of the thrombi within the pulmonary arteries, and it is also used for the assessment of the severity of the obstruction. So what are the findings in this CTPA related to pulmonary embolism? So the first one, which is considered to be diagnostic, which is considered to be a hallmark or pathognomonic for PE, is the pulmonary artery filling defect. There is a presence of the central or eccentric filling defect within the contrast enhanced pulmonary artery. This is pathognomonic for pulmonary embolism. As you know that the clot appears darker and has a low density with a high density, that means bright contrast filled artery. So the diagnostic finding on CTPA for pulmonary embolism is the pulmonary artery filling defect. There are other findings also which are seen on different views, like on axial section of the pulmonary artery. The findings are railway track or the polo main sign, as you can very clearly identify it over here also. Now this one is the a circular filling defect which is surrounded by the contrast, this one, and this is known by the name of polo main sign. The railway track sign, which is seen in the longitudinal views, is a linear filling defect extending along the artery. So these are the another findings which are present or which could be identified on the pulmonary embolism. Yes, the most important one is the cutoff sign, another diagnostic finding, which is the abrupt termination of the pulmonary artery due to pulmonary obstruction. Simple. Due to embolic obstruction. Simple. So it is seen in large proximal pulmonary embolism affecting the segmental or the lobar arteries. So this is cutoff sign. There are other signs also like mosaic perfusion pattern, which is the perfusion defect. It is a heterogeneous lung enhancement due to areas of hypoperfusion, which is obviously caused by the embolism, and it is seen in case of subacute or chronic pulmonary embolism. Now, pulmonary infarction on the CT, it is actually similar to what we have seen on the X-rays in the form of Hampton's hump. So, what is basically this pulmonary infarction, which is a late complication? It is a wedge-shaped peripheral consolidation. Location, majority of the times, in the lower lobe. Then, the right ventricular strain signs, which is a feature of the severe pulmonary embolism. Here, the right ventricular to left ventricular ratio is more than 1. That means the right ventricle becomes enlarged compared to the left ventricle. So these are all the signs on the basis of which the pulmonary embolism is identified on CTPA investigation. Now another investigation that you might have heard about, in particularly the options, are the ventilation perfusion scan. You know, this ventilation perfusion scan is the second line of investigation. It is not the first investigation to deal with. And where exactly it is required? It is required where the CTPA is contraindicated. And what are those conditions? If the patient is having a renal failure, if the patient is allergic to contrast, like iodine contrast allergy, or particularly in case of pregnancy. To reduce the radiation exposure to the fetus. All of you know that the ventilation perfusion scan is a nuclear medicine test which is used to diagnose the pulmonary embolism by detecting the ventilation perfusion mismatch. It is primarily used when CT pulmonary angiography is contraindicated. Now, what is this mismatch, or what is the principle behind this mismatch? Normally what happens is there is a ventilation scan where there is an assessment of the airflow in the lungs. Now, patient inhales the radioactive gas or aerosols like xenon 133 or technetium 99 DTPA. And the imaging is identified, and the areas of airflow in the lungs can be seen with the adequate ventilation. So the ventilation scan is being prepared. After that is taken is the perfusion scan. Now here in this perfusion scan, what is being done? It is for the, obviously it is for the assessment of the blood flow in the lungs, and what is injected are the radio labeled particles like technetium 99 macro aggregated albumin. So it travels through the pulmonary arteries, and this shows the areas of the adequate perfusion. Now, if the ventilation and perfusion both are same in the areas, it is normal. But if there is a mismatch, like a normal ventilation but reduced perfusion, like in this case, this is how the ventilation images are being identified on different views. But here the perfusion image is present in the upper lobe, it is absent in the lower lobe. So it is a mismatch. If this mismatch is present, then it is highly suggestive of the pulmonary embolism. And how is it being identified? Like, what are the ventilation perfusion scan findings in the pulmonary embolism? You see, if there is a matched defect, that means ventilation and perfusion both are reduced in the same area, then it is obviously not the pulmonary embolism. It might suggest pneumonia, the lung collapse, or the chronic obstructive pulmonary disease. But if there is a mismatched defect, that means ventilation is absolutely normal but reduced perfusion in specific lung segments, as we have seen in these cases, where ventilation is absolutely normal but there is a reduced perfusion in some of the segments, then it is highly suggestive of pulmonary embolism. Now, if this thing happens in multiple segments, then it is having a high probability of the pulmonary embolism. So hope you have understood that what is the role of this ventilation perfusion scan findings in pulmonary embolism. So based on these mismatches, the probability interpretation is done based on PIOPET criteria. So what is PIOPET criteria? It is the prospective investigation of pulmonary embolism diagnosis. That means based on the probabilities, what is the next step? Like, if the probability is very low, then the next step obviously that the PE is ruled out. But if the probability is low, then consider clinical probability and further testing. But if the probability is intermediate, then it requires additional imaging like CTPA, Doppler USG of the legs in order to identify the cause. But if the probability is high, then the diagnosis of PE is done and you have to start with the anticoagulation management. So this is the role of ventilation perfusion mismatch. Now, what is the role of direct pulmonary angiography? The pulmonary angiography is no doubt the gold standard for diagnosing the pulmonary embolism, but it is rarely used. Why? Because of its invasive nature and the availability of CTPA already. So it involves direct injection of the contrast dye into the pulmonary arteries under fluoroscopy or or digital subtraction angiography. And what are the indications? When there is an inconclusive CTPA or ventilation perfusion scan, which is rare. Second is evaluation before catheter directed thrombolysis or embolectomy in a massive pulmonary embolism. That means related to the therapeutic measures. And the assessment of the chronic thromboembolic pulmonary hypertension for surgical planning. So these are the specific indications. Actually, no question is directly asked based on this. What they usually ask you is that they used to keep it in the options, but CTPA is basically diagnostic for the pulmonary embolism. Now, what is the image interpretation? First thing that you have to go for obviously is the catheter insertion in the femoral or the jugular vein, that means central. And It has to be advanced into the pulmonary artery under the fluoroscopic guidance. Then the contrast has to be injected. And what is the image finally? What is the image interpretation? It is normal pulmonary arteries appear uniformly opacified in case of normal, but the pulmonary embolism appears as a filling defect. That means it is a dark area where the contrast is absent, as it can be very easily identified in this image, right? So this is the interpretation of the direct pulmonary angiography, which is obviously rare today because of the wide availability of CTPA. This is all what we have talked about. Now, if you go back to the question, now the question might become much easier for you to identify and answer it accordingly. We have already talked about that the question was related to pulmonary embolism, and which of the following is the most appropriate diagnostic test to confirm the suspected diagnosis. And the answer for this question is CT pulmonary angiography. We already came to know that D-dimer test is just to rule it out when the probability is low. Ventilation perfusion scan when the CT pulmonary angiography is contraindicated. Direct pulmonary angiography is more invasive and is less required today in presence of CT pulmonary angio. And what are the findings of the CT pulmonary angio? We have already talked about. So I hope the session was of help. All the best for your future examination. It has been already announced that June 15th of 2025 is your NEET PG examination. All you need to prepare, what is the most important thing for you to prepare regarding these examinations is that on the day where you are facing the screens, at least 10 questions in the beginning of the examination itself in a row should be identifiable. 10 out of 200 questions, if you are in a row, you are able to identify early in the examination, that means you are done. Congratulations. और जितने भी प्रिपरेशन करनी है वो इन्हीं पहले 10 क्वेश्चंस के लिए, in order to build that confidence in the beginning of the paper. All the best for your future examinations. In case you do not want to miss any update, please join our Telegram group. Thank you very much.